So welcome everyone. My name's Sarah and I am I'm one of the community members at PCNA, and today we're going to have a webinar on scope of practice and how to know yours and how to defend it. And I'm so excited about this webinar. And I know I say that every time, but this one in particular, I can't wait to hear what Kylie and Kathryn have to say, because I think this is such an important conversation for us as palliative care nurses. So before we get going, I just do some housekeeping, and I'm going to do an acknowledgement of country, and then introduce Kylie and Kathryn, and then just a little bit about the topic before I hand over to them. So housekeeping, I know a lot of you are at work, if you have the capacity to put your camera on, please do it, just because it helps us feel like we're not talking to an abyss of the internet. Like it just makes us feel like we're connecting with people. It's good. If you have a microphone, turn it off so that we don't hear your background noise. While Kylie and Kathryn are speaking, if you think of a question or you have something to add to the conversation, pop it in the chat, because at the end, after they speak, I'll ask those questions. And the more questions, the better. So as they're talking, think of questions, because these two, it's great to have them in the room to use their brains. So let's do an acknowledgement of country. So at PCNA, we acknowledge that we all live and work on the sacred lands of the First Nations people of Australia. Each person today joins us from a different location, and I'm joining you from the land of the Larrakia people in Darwin. We recognise and respect that this sovereignty was never ceded, and we acknowledge that the air, the waterway, and the lands that we work on hold deep significance for the First Nations people. We honour, we respect, and we admire and celebrate Aboriginal and Torres Strait Islander people who represent the world's oldest culture, oldest continuous culture. Their strength and resilience and deep interconnectedness with living things ground us as we work as palliative care nurses. So thank you for joining us. Before we get going, I just want to introduce Kathryn and Kylie. So Kylie is a very experienced registered nurse with decades of nursing experience, and particularly decades of nursing community palliative care management experience in senior roles in community palliative care. She's currently the Secretary of Palliative Care Nurses Australia and an improvement facilitator at Peacock. So thank you very much, Kylie, for being here. And Kathryn Bennett is a nurse practitioner at Eastern Palliative Care, and she also brings decades of clinical nurse practitioner experience, but also a wealth of knowledge in senior roles across a community palliative care service. So thank you, Kathryn and Kylie, for joining us. So
thanks, Sarah.
Before we hand over to you, and the way we're going to do it is Kylie and Kathryn are going to speak, so you won't hear much more from me very soon. I just wanted to speak about the context. Why did I think that this was an important thing for us to talk about? And I think as palliative care nurses, we have such a specialist skill set, and it's so unique, and it adds so much to the patient's experience. And I know when you start, especially when you start, you kind of feel like you're not sure where the boundaries are of our skill set. And then on the flip side, when you're more senior and you work in teams, there's a strange moment where you might have a well-meaning team member tell you what they think your scope of practice is. So I think as palliative care nurses, we need to get informed. And this is where Kylie and Kathryn are coming in. So I'm going to hand it over to you two now. And thank you very much for being here.
Thanks, Sarah. I'm going to kick things off. It's so great to see so many people in the virtual room that I know and love, and people that I'm just getting to know. So welcome, everyone. Kathryn and I were having a chat before this about, we hope that we give enough of an expert conversation here about scope of practice. But I think we've been working in palliative care long enough to know what's within our scope and what's not. rest assured this is going to be recorded, so if you do have a colleague that misses out on this presentation, they can catch up on it later. So can we go to the first slide, James? Actually, we can go to the second slide. That's just the title page. So what we're going to cover today is we're going to define what scope of practice is, because we hear a lot of people talk about scope of practice and working to the top of scope, but very often we don't think that there's a solid understanding about what it actually means. We're going to cover how you determine your own individual scope of practice. We're also going to cover the context and how context plays a role in scope of practice, what your organisational responsibilities are around scope of practice. Kathryn's going to talk to advanced practice and scope expansion, and we're going to talk about enablers and barriers to expansion of scope. So what prevents us and what enables us to be able to work to the top of our scope. We are going to talk a bit about palliative care nursing specific scope, and then there'll be some references available, and I've tried to hyperlink as many of them as I can. It's actually on page 15, the references, so that's a little typo there. So we'll go to the first slide. There's a lot of content to get through today, but I'll try and make it as painless as possible. It's good to always start with some definitions, and there's a few definitions floating around scope of practice, but I've picked out some of the ones I particularly like, and this first one is from the Nursing and Midwifery Board of Australia, the NMBA, who they'll be referred to from here on in, from 2017. Scope of practice is that in which nurses are educated, competent to perform, and permitted by law. The actual scope of practice is influenced by the context in which the nurse practices, the health needs of people, the level of competence and confidence of the nurse, and the policy requirements of the service provider. So when nurses complete their undergraduate training, they learn a generic range of broadly applied skills that can be applied across a variety of settings in care. For example, they learn how to complete a patient assessment. They learn how to complete vital signs and how to complete a progress note, and they learn about ethical practice and a whole range of other things that nurses learn about when they're doing their undergraduate degree. As that nurse develops in their career, they very often choose an area of specialisation where their existing skills are honed and new knowledge and skills are attained. This expands the scope of practice for an individual nurse, and that experience improves the confidence of the nurse as their knowledge, skill and competence base grows. So scope of practice is therefore difficult to define for any individual nurse, as each individual nurse who you work with in your team and for yourself, you have your own unique experience. We know that nursing is increasingly diverse and that nurses work in a variety of environments, all of which help to provide the context to a nurse's scope of practice. And whilst the term scope of practice is referred to in documents, guidelines, the literature, it remains as described by Birks and others, an elusive concept that is poorly defined. If you're looking for any literature around this, Birks is an author, Melanie Birks, who has created a lot of really good articles in this space. Words like scope, standards and competencies, as articulated by Birks and others in 2018, are often used interchangeably. So you might be talking about scope of practice and someone might go, oh yeah, there's competency standards for a palliative care nurse, but that's not the full story in regards to scope of practice and what your individual scope of practice is. So if you search Google, libraries, other sources of international information to find a scope of practice for a palliative care nurse, you may, like I, come away quite disappointed and find that clarity is missing in the space. And like I said, we'll be able to find competencies for a palliative care nurse, traits for a palliative care nurse, and multiple guidelines and standards by which nurses practice in Australia and in international settings. Documents that you may find often contain concepts that are really too broad to provide adequate guidance to the palliative care nurse, and particularly to a novice palliative care nurse. I think some of the more experienced palliative care nurses in the room know full well what their scope of practice is, And it's fair to say that confidence grows as one ages, which is pleasing to know. We might get more wrinkles, but we get more wisdom. So that's joyful, something to look forward to for some of the younger people. So let's look to some of the standards that inform our scope of practice, that guide our practice as nurses. Some of those standards are produced by the NMBA, Nursing and Midwifery Board of Australia. And the ones specifically that might inform our scope of practice are the Registered Nurse Standards for Practice, the Enrolled Nurse Standards for Practice, if we have any enrolled nurses in the room, Nurse Practitioner Standards for Practice, and we probably don't have any midwives in the room, but they have their own special standards of practice. There's also continuing professional development guidelines, which guide how much PD we need to do each year. There's safety and quality guidelines for NPs. And there's also information about mandatory notifications, social media position statements and policies. There's a framework for assessing standards of practice, code of ethics, code of professional conduct, and then there's a national decision-making framework for nursing and midwifery. And I bet that there's people in the room that haven't looked at the national decision-making framework for nursing and midwifery, but it's worth a read. It's an interesting document that is found on the NMBA website. There's also documents that have been produced by the Australian Council of Nursing. Is that right? Is that what they're called? The ACN? I haven't really written it down. It's Council of Nursing, isn't it? Scope of practice, registered nurse in the community setting. That's quite a good document as well. So if you're working in the community, they've got a position statement around registered nurses working in the community and what their scope of practice might be. So that's worth a read and it's not too lengthy. There's also the ANMF or the ANF more broadly, so the national body that have national practice standards. They have national telehealth professional practice standards for nursing and midwifery. They also have national informatics standards for nurses and midwives. And then there's the PCA standards, which are the National Palliative Care Standards. So there's a set of standards for specialist palliative care providers, and then there's a set of standards for all health professionals and aged care services. So for people other than specialist palliative care providers. And I think the ACN is the Australian College of Nursing. I think I remembered somewhere back in my frontal lobe I found that. So nurses are responsible for making a judgment about when an activity is within their scope of practice and when it is not. The nurse is also responsible for delegating, initiating consultation and collaborating with and referring to other members of the healthcare team. So these decisions, as we know, as nurses that work in interdisciplinary teams, are made in a collaborative fashion with the person who is in receipt of palliative care. Their relevant family, their relevant carers or other members of the healthcare team. So these decisions that nurses make about their scope of practice should be based on considerations of the person's health status and any relevant social determinants to their healthcare, lawfulness, what's within legislation and common law, compliance with evidence, professional standards, regulatory standards, policies and guidelines, and the context of practice and the health service provider, employers, policies and protocols. So you might be able to do something within your scope of practice, but if your employer doesn't support that practice, then it might be outside of the scope that you're allowed to practice in within your organisation. There also needs to be organisational support, sufficient staffing levels and appropriate skill mix for whatever practice you're undertaking. The term scope of practice is described differently across the Australian jurisdictions, and some state-based policies describe the collection of functions of the nurse, which is very kind of task-orientated. These policies and descriptions can be indirect and unclear in the definition of scope of practice, and nurses may well have to interpret their own scope of practice informed by all of these standards and guidelines and other context-specific documents. So Burke's does speak to the ambiguity that exists in understanding scope of practice and describes that the word scope could be the problem. So the word scope is defined as the extent of the area or subject matter that something deals with or to which it is relevant, which is in itself vague. The phrase scope of practice implies clear delineation of one's role as a nurse, but the truth is detailed scope of practice, particularly in relation to palliative care and other specific areas of practice, is ill-defined. That's a lot of talking, and I'm glad that that slide's done. So can we move on to the next one, James? We've got a couple of other definitions here that I quite like. This one is from the Department of Health. The top one is from the Department of Health and Ageing. They released an issues paper entitled Unleashing the Potential of Our Health Workforce Scope of Practice Review. And their definition of scope of practice is professional activities that a practitioner is educated with skill or knowledge, competent and authorised to perform, and for which they are accountable. Individual scope is time sensitive and dynamic. So it's fluid as we learn more, as we gather more information, as we get more knowledge, whether it's formal or informal, our scope of practice changes. Scope of practice for individual practitioners is influenced by the settings in which they practice, the health needs of people, the level of their individual competence and confidence, which is really an important word, I think, and the policy requirements, so the authority governance of the service provider. Also, the International Council of Nurses have a scope of nursing practice document, which is pretty good. I think it's only about 6 pages long. They produced it in 2013, so it's getting on a little bit now, but it's worth reviewing. It's not too lengthy. I've included it in the references, but I quite like their definition here. The scope of nursing practice is not limited to specific tasks, functions, or responsibilities, but is a combination of knowledge, judgment, and skill that allows the nurse to perform direct caregiving and then evaluate its impact, advocate for patients and health, supervise and delegate to others, lead, manage, teach, undertake research, and develop health policy for healthcare systems. So I think that definition really speaks to how broad our role can be as nurses across all different.
Smells very nice. Oh, it's my.
Brown, mute
Yes.
yourself.
I can hear you talking, Jessica Brown. Can you maybe mute yourself, doll?
She's stop talking now. Continue on.
Okay. Okay, so next slide, James. So we go to the section around how do nurses determine their scope of practice. We've talked about all of the professional documents that nurses use. Also, nurses might use their colleagues. So if you're new to a practice or you're a novice nurse in palliative care, you might be asking your colleagues what's best practice in this space, and you might have to understand the norms and the culture of whichever team you're working in to understand what they think is best practice and what is reasonable in the scope of a palliative care nurse. You might have to use your personal judgment about what you feel confident and safe doing. And you might use other people's judgment. So say that you've got a clinical nurse consultant or a manager of nursing. They might think that you are quite competent in an area that you maybe don't feel so competent in, or you might be overconfident and they might think that you need a little bit more education in a certain area before you get involved in that. You also might need to seek professional legal advice, and I speak to that specifically around any mandated reporting requirements that exist for registered nurses. I don't think that you need to rush out and get legal advice about whether you can perform any tasks on a day-to-day basis, but if you are involved in a situation where you might need to mandatorily report, it might be helpful to seek advice from someone external. Considering patient outcomes is also important in determining your scope of practice. So if there's something that a patient might really benefit from, and this probably speaks to areas that are more remote and rural, and you don't have the skills in that particular area to perform that intervention, you might need to think about how you develop those skills so that that patient can have the best outcomes. Scope of practice guidelines attempt to define the boundaries of practice or the outer limits. So we sometimes hear people saying, that's outside of my scope. So that speaks to that individual nurse not being confident around doing whatever that practice is. So obviously rules and laws must be observed, and that's the upper limit of practice, and there's individual accountability for decision making. ENs, RNs, NPs all have different scopes of practice and different professional boundaries. And this comes to the point where we're going to ask the audience a question about what resources, in addition to these, that you might use to determine what your scope of practice is. So if anyone wants to unmute themselves and chime in, please feel free to do so. Are there any that are missing?
Or you can put it in the chat.
Okay, no one's going to chime in. That's okay. There's a lot of information so far, and maybe people feel that that's a comprehensive list as to how they determine their scope of practice. We might move on to the next slide. Thanks, James. Which is around scope of practice and context. So context can refer to the geographical location of the nurse, whether they're, which state they're in. Are they in a remote situation, a rural situation, or a metro situation? What the setting of care is in which the nurse is providing palliative care. Are they in an inpatient facility? Are they working in an outpatient's clinic, or are they in the community setting? What the type of service is that's being delivered, the nursing level classification, and the type of specialty. So obviously we're talking about palliative care today. Can anyone in the room think about how geography might influence scope of practice for someone? So please feel free to unmute yourself.
I can go, Kylie.
Go, Sarah.
Okay. So I've worked in lots of different contexts and lots of different environments. And in, say, for example, I remember in Wagga when I was, that we just didn't, it was just the nurses for the palliative care service. And so we really became the OT. We became the speech pathologist. We became the the volunteer coordinator. There was our role within limits became larger just because that was what was needed for the patient. There just wasn't so geography matters because there's not necessarily a team around you to do the other bits of the job.
Mm-hmm. So Sarah, you were essentially jack of all trades.
Yeah, and that's what the nurses just had to do because of the reality of the service that they were in. Yeah.
Can you think, Sarah, or anyone else who wants to chime in, about how the setting of care might influence your scope of practice? So if you're working in the community or if you're working in an inpatient setting, how might that influence your scope of practice? Can you think of any examples?
We've got some answers in the chat, Kylie.
Oh, good.
Andrea Miss O has said, agree. So we'll start with Nicole. Nicole said, scope may be affected by resources available in certain geographical locations. And then, and then Kirsty said, agree, reduced access to availability of although that was Andrea, reduced access to or availability to other health professionals. And then Liv has said, who's in Tassie, I think Liv has said exposure or lack of exposure to skills, knowledge, and clinical situations.
Absolutely. I think a really good example of how scope of practice can be a bit fluid and be influenced by external pressures is the pandemic and how that influenced our scope of practice as palliative care nurses. I know in a lot of environments, the palliative care nurses were kind of doing everything and were the primary people visiting during certainly lockdowns in Melbourne. And so, like Sarah said, there was a lot more versatility, extension of the scope of practice of the palliative care nurse into areas that they maybe weren't necessarily involved in prior to there being a pandemic. We just had to get the job done. So I'm sure that you can remember that space and how the nurse's role became so important to patients and carers, and we were kind of doing everything in those homes. If we can just move to the next slide, James, that'd be awesome, which is around organisational responsibilities. So what does the NMBA say about the responsibilities of organisations in terms of scope of practice? They say in their document, their decision-making framework, which I referred to before, which is really worth reading, that organisations need to provide sufficient resources to enable safe and competent care. They need to provide policy and practice and processes that support the development of nursing practice within a risk management framework. There is to be no substitution of health workers for nurses or midwives if the knowledge of nurses and midwives is required, and I think that's a really important point. And there should be no pressuring, directing or compelling of nurses to engage in any practice that falls short of or is in breach of professional standards, guidelines, ethics and practice for their profession or codes of conduct. And I'm sure before it comes up, nurses may have felt challenges in this space, in particular around voluntary assisted dying and legislation changes that have occurred around the country. So these are the responsibilities of an organisation in regards to scope of practice. I'm going to shut up for a minute and hand over to Kathryn Bennett, who's going to talk to the next slide. Which is around advanced practice and scope expansion. If we can go to that slide, James. Thanks.
Thank you, Kylie. So, the Nursing and Midwifery Board has defined advanced practice as nurses who practice at an advanced level, which incorporates professional leadership, education, research, and supportive systems into their practice. Their advanced practice generally includes relevant expertise, critical thinking, complex decision-making, and autonomous practice, and is effective and safe. They work within generalist or specialist contexts, and they are responsible and accountable in managing people who have essentially complex healthcare requirements. Advanced practice in nursing is demonstrated by a level of practice, and it's not necessarily by a job title or a level of remuneration. However, there are many roles that are considered as advanced practice roles, such as clinical nurse consultants, nurse coordinators, and nurse practitioners. The literature describes that the pressure on the health system in relation to the ageing population and healthcare demand is indicating the need to expand the scope of nurses in Australia and around the world. Add to that increasing work challenges throughout the entire healthcare sector, especially since COVID. There is a much greater focus on nurses working to their full scope and further scope expansion of nursing roles, especially in the rural and remote areas. Can anybody think of any scope expansion that you may have experienced in the last couple of years, and do you think it's been positive? So we'll open that up to the floor, I guess. Might be a couple of answers already there, but pop it in the chat. Thanks, Sarah. Nothing. It's okay. So one of the latest sort of expansions of scope, which is pretty exciting, is the a registered nurse prescribing model, which was approved by health ministers late last year, and which is likely to roll out in the middle of this year. Now, the full details of what that exactly is going to look like is not clear yet, and it's going to depend again on context and setting of care. And this is going to enable suitably educated and qualified RNs to prescribe Schedule 2, Schedule 3, 4, and even Schedule 8 medicines in partnership with an authorised health professional under a prescribing agreement. This model will certainly improve resource use, especially in rural and remote areas, and where we already know access to medical care is really challenging for many patients. The prescribing model will hopefully enhance care coordination by allowing designated registered nurses, registered nurse prescribers to manage medications, and that may include symptom management medications and end-of-life meds, which can free up other healthcare professionals to focus more on complex areas of patient care. There are new registered nurse prescribing accreditation standards, which have been developed by the Nursing and Midwifery Board of Australia, along with the Australian Nursing and Midwifery Council, to ensure that designated RN prescribers meet the NPS Medicine-Wise National Prescribing Competency Framework. And this framework really describes the competencies and expectations for appropriate and safe, effective prescribing across all relevant health professionals, including nurses, doctors, pharmacists, that kind of thing. To apply for the endorsement as a registered nurse prescriber, RNs must meet stringent requirements, including completing postgrad qualifications in the area that they want to specialise in, demonstrating adequate clinical experience in that area, and they also now need to complete a 6-month period of clinical mentorship with an authorised health practitioner post-endorsement to help RN prescribers develop confidence in their prescribing. So the nurse practitioner scope is really built on the platform of registered nurses and the RN scope, and must meet the regulatory and professional requirements for Australia. Nurse practitioner practice is also guided by the Nursing and Midwifery Board of Australia's Nurse Practitioner Standards for Practice, which covers the 4 main domains of NP practice, which is clinical, education, research and leadership. Similar to RNs and other ENs, NP's scope of practice is defined by the context and setting in which they work and by their level of education and experience. So NPs can certainly expand their scope at any time, but they need to undertake relevant postgraduate education and skill development in the area which they intend to expand their scope. And services certainly need to develop government frameworks to ensure that NPs can, in fact, work to their full scope when they have the education to do so. I did see a quick question pop up there, which I may as well answer now, in relation to, do you have to be a nurse practitioner to become a registered nurse prescriber? No, you don't. So there is certainly, there's going to be limitations around what these people can, nurses can prescribe. And there's also got to be some sort of arrangement with a healthcare, another healthcare professional, probably likely a doctor. And really, I'm not sure of because this is sort of a new development really, there's still a bit of resistance from the medical board in regards to especially prescribing of S8s. But I think that there will be very clear sort of prescribing processes, and that will certainly probably be developed by individual organisations themselves really to determine what they're comfortable with. But it's certainly, I'm super excited about that, because we all know that especially specialist palliative care nurses, we're often really the ones that are recommending and providing doses and, you know, converting opioids. And so to be able to have some flexibility when we've got limited resources in being able to prescribe, and I imagine it's going to be fairly routine kind of medications, nothing too complex. But I think that's a good space for everyone to watch, because I think it's certainly I think a step forward in progressing the scope of practice for nurses. So I'm pretty excited about it. Next slide, please, James. So what are the enablers of to expand one's scope of practice? Obviously, education and continuing professional development is very important. Leadership and organisational support is crucial, really. Confidence in the age of the health professional often promotes more self-assurance. An Irish study actually looked into the scope of practice decision-making and found that nurses that were over the age of 50, so that includes me now,
And me.
yeah, and most of us probably, were less likely to consult their line managers compared to younger cohorts of nurses, and were statistically significantly more likely to recognise their accountability when delegating decisions, with stronger reliance on their own professional judgment when making decisions about their scope of practice. Patient need, professional satisfaction, maximised health outcomes for patients are also really important enablers. The Australian College of Nursing has produced a position statement that Kylie touched on earlier on the scope of practice of registered nurses in the community. This statement describes that ensuring that nurses work to the full extent of their scope in the community enhances health service access and delivery, and increases job satisfaction and retention of nurses, and it improves the healthcare outcomes for patients. This working to full extent of scope in the community will certainly maximise the value of an at times underutilised workforce to meet communities' healthcare needs, and the authors describe that the health outcomes are maximised as service delivery is optimised. Next slide, thanks, James. So unfortunately, there's many barriers to working to full scope of practice. Poor communication, inconsistent recognition of qualification and skills, trust is a big thing between team members, clear lack of support, workload, lack of remuneration. You know, often people don't want to increase or expand their scope or work to full scope if they're not sort of being remunerated for that. Professional indemnity insurance can be a limitation or a barrier sometimes. Lack of strong clinical governance, institutional practices and policies, legislation. For example, drugs and poisons acts differ across different states and territories. Workplace culture, leadership, geographical location can be really significant barriers, along with the fear that we often have of legal consequences of working outside of our scope. Referral into services and other disciplines can also be sometimes quite restrictive for nurses. Healthy team-based care and relationships contribute to palliative care professionals working to their full scope, rather than in teams where professionals are siloed from each other. We can't possibly know each team's specific skill set, particularly in large teams or where health professionals are working from different sites and hospitals. This is where we trust in teams and in our colleagues' professional boundaries, expecting those that we work with, work alongside, to also work within their scope of practice. Understanding what team members do and how they do it is described as being an important first step in enhancing one's understanding of our colleagues' scope of practice. There was a white paper completed by the Australian College of Nursing called Achieving Quality Palliative Care for All, the essential role of nurses in 2019. And it described in relation to the barriers of practice, and I quote, "The ability of nurses to engage with potential service users without the need of a physician referral, and in terms of access to existing patient health records for the purpose of communication with other members of the patient's team. Health services need to ensure policies and communication systems exist that enable needs-based referrals for nursing service, which facilitate communication across the team." So can anyone, and I'm sure that we've all got examples of this one, can anyone think of a time when they have had concerns about a colleague's boundaries or working outside their scope? Happy to unmute yourself and speak, or pop it in the chat.
I think if no one's going to speak, Kathryn, I think talking a little bit more about policies that impact and provide a barrier for us working to the top of our scope. I know that there's some palliative care units or services that will only accept a referral from a doctor, yet a patient or a carer can refer their loved one, but a nurse can't refer to the service. So barriers like that can be changed with policy development and process development can really influence how we can practice to the top of our scope. Nurses that are skilled in palliative care should be able to refer to an inpatient facility or to another provider, healthcare provider.
One of the other ones that sorry, Kylie, were you about to say something?
No, I was just going to say there's a couple of questions in the chat, but we can go to that after you
No, we
finish
can
what
go.
you were going to say.
I'll read Jennifer's. Jennifer's said, so you were talking about the RNs and the prescribing, and Jennifer said, it's great. And I guess the medications that the nurse can prescribe will be dependent on whether the doctors in the area of work are agreeable on the nurses initiated the prescribed medications. It's very interesting, right? Can you speak a little bit about that, Kathryn?
So all I really know about that is that there needs to be some sort of agreement between the nurse prescribers and a registered, I imagine a registered medical professional. So I think it's going to be very dependent on, again, in terms of context and experience and, you know, setting up what that that health professional believes the nurse prescriber has competency in. And I think that might be very different depending on setting, you know, context, geography, and that arrangement between the nurse and the registered health professional. So I'm really not sure exactly what that's going to look like, but it might be that people can prescribe some of the nurse initiated medications. You know, it could be that you could prescribe, I think it's really going to depend on that agreement between the person that's overseeing the prescribing.
Kathryn, can I speak to that? I'm
Yes.
Jenny. I put the question in, and I think that space will be interesting. I'm a nurse practitioner in aged care, and when I prescribe for residents with at end of life, there are GPs who won't let me prescribe for their patients, or they will say that I'm prescribing too much, or you know, they don't like my hourly morphine with no with no limit. They want to give the morphine every 6 hours for someone who's dying, not as they need it. So I think there's still, I mean, we know, don't we, there's a lot to do in this space anyway. I mean, I am lucky that I'm not rural and remote, or am I not lucky? Maybe I'd have more flexibility if I was just on my own, be able to flex that. But yeah, I think I guess I'm concerned, and I see it. We have, even when I was a CN in palliative care in a specialist ward, and you would, suggest or recommend, and mostly, and I'm not dissing the doctors, I think they're amazing and we need them, but there would be pushback on, but you're just a nurse, you can't. You can't recommend this drug for me to prescribe, etc. Even giving evidence, even giving your rationale to support that. But I am excited about nurses being able to do it.
Yeah, and I think that we've had those challenges for a long time. I think those challenges are still going to be something that we're going to have to work with. I've certainly had less resistance from doctors than I was expecting since I became a nurse practitioner, and have always sort of been quite well supported by GPs to prescribe. But I think it is going to be an interesting space to watch, and I look forward to getting some more details about what that might look in different settings and circles, for sure.
Maybe it's just me.
Oh no, I think it is very doctor dependent, or medical practitioner dependent, and I think it can vary greatly. But yeah, thanks Jennifer. So next slide, please, James. So the scope of practice of a nurse in palliative care. Shelyuvapa and Selvendran speak 2022 speak to the scope of palliative care nurses in Australia, and they suggest that in addition to the standards of practice that RNs must comply with, that palliative care nurses should also have specific training and competency, especially in the administration of S8 medications, which are obviously context related and comply with the palliative care Australian standards. This often includes, as we know, and Kylie touched on earlier, includes knowledge around opioid conversions and the principles of opioid rotations. They need to provide comprehensive assessment of needs, the development of care plans. We often care for the carers including carer education, providing care that includes patient education, and obviously the care of the terminal patient, along with facilitating transitions not only within services but between services also. And although some palliative care services do have specific bereavement counsellor roles, often palliative care nurses are providing grief support to carers, even before and after death. Next slide, please, James. So one of the most important roles or scope of palliative care nurse practitioners, palliative care nurses, is ensuring that the patient is given a voice and that it's the loudest voice at the table. I think nurses tend to advocate quite strongly for patients, and I think in palliative care setting that's even more important. Palliative care nurses really need to have that advanced communication skills to be able to facilitate patient-centred discussions around goals of care and advanced care planning and end-of-life preferences, including preferred site of care and death. Palliative care nurses also provide complex supportive care, incorporating collaborative practice, engaging continual quality improvement and evidence-based practice. They also provide care coordination often and negotiate with other service providers. They have expertise in symptom management and they ensuring the early identification of problems, not only providing anticipatory and responsive care, but also timely care to patients and their carers. Next slide, please. So this is where we kind of open it up and ask people, if you've ever had to defend your scope of practice, or any other questions really at this point. Feel free to unmute yourself or throw it in the chat.
Maybe I'll start and I'll give people time to think of questions, but I'll give an example that someone else gave to me that kind of gave me the idea for this webinar. So I know of a group of CNCs who have all had decades of experience, who were working within a hospital in a team, and they had suddenly been told by the doctors in charge that they were no longer able to recommend medications and that was out of their scope of practice. And that really shocked me, and I know that was quite a battle. So that's an example that I've heard of. What do you reckon they should do? What do you reckon people should do in that situation, Kathryn?
Well, firstly, I just wanted to find out, was that situation resolved or is it still a situation?
I think in the end, the doctors realised that they could not, like the whole system would break down if they were going to be if their CNCs couldn't do their job. So I think in the end, the doctors decided that the nurses could recommend medications. But it just seemed that was probably the point where I was like, that doesn't feel right to me, that there should be another profession saying what another person's scope is. Like,
it's really it highlights another barrier, I guess, to people working to their full scope. And I think what do we recommend people do in that scenario? I think, certainly open the lines of communication and advocate for your scope, and provide rationale for why that can't happen. I mean, at EPC a little while ago, when we were reviewing, many years ago now, when we were reviewing whether or not we were having lots of trouble getting emergency medication orders back from GPs, incorrect doses, not filled out correctly. And we wanted to be able to recommend medications on that form so that we were getting correct doses back. And we spoke to ARPA and the Drugs and Poisons, and we consulted a lot of people really about whether it was in the scope of practice of nurses to be able to do that, specialist palliative care. And there was a lot of sitting on the fence by a lot of those organisations, but at the end of the day, they decided, they said, look, if this is a specialty area and you feel like you have the confidence and the the education and that kind of thing to make these recommendations, at the end of the day, it's still up to the prescriber to prescribe them. And so it was agreed that we could actually put on our support medications, pick the medications and also the doses, but we also provide them with rationale about why we've chosen those. So we put what opioids they're currently on and what their breakthrough dose is. And again, it's a suggestion. We still can't, we're still not prescribing that. We're just suggesting or recommending to general practitioners that often don't have a lot of experience in the palliative care space, especially prescribing end-of-life medications. So that's certainly how we got around a problem. But yeah, I think Jess has got her hand up.
I do. I'm invited to speak this time. Sorry about before, Kylie, when my microphone went rogue.
No worries.
So I think there's a few things that I've noticed sort of transitioning from the community into the acute sector and being a CNC in a hospital-based environment. The first thing that sticks out to me is the impact of one person acting outside of their scope and the impact that has on the rest of the team, and sometimes those knee-jerk reactions where the scope of the rest of the team who are acting within their scope can be reduced out of fear because one person has acted outside of their scope. So these discussions are so super important because nurses really need to understand their scope, because it can be so fluid. Because the consequences for the rest of our nursing colleagues can be quite significant. And I think in terms of defending our scope of practice, I think there's a few, we have to take responsibility as well. And exactly what you're saying, Kathryn, is about being quite careful about how we're doing it and making sure that we're making it very clear that it's a suggestion. So when I'm making recommendations to a treating team at the hospital, I am very, very clear that this is a suggestion, and I'm very, very clear about my role. So I put my role on every single message that I send to everybody every time to make it clear that I'm a CNC and this is a suggestion. But like you said, Kathryn, most of the time people are just really grateful to have those suggestions. But we do need to be aware that sometimes in busy places, and everywhere's busy, whether that be in a GP office or in a hospital setting or anywhere that we're working, those prescribers are really busy. And sometimes they will just take what we say as gospel and they will just prescribe it based on our recommendations. And while that's their responsibility to do their due diligence as a prescriber, we need to be aware that the recommendations that we're making are often taken as very, very reliable. And so we need to be very careful about what we are suggesting and making sure that if we're not sure, then we're escalating it and getting that assistance from another advanced practice nurse or our medical colleagues, whoever it might be, to make sure that we're doing the right thing and suggesting the right thing.
I think that's so true, Jess. I think we've all been in the situation where we've had a new nurse start in the team who's possibly a little bit overconfident, and it speaks to the Dunning-Kruger effect when you're new and you don't know that much about palliative care and you learn a little bit and you think your confidence is really up here, But the people who know the most about palliative care actually understand all the things they don't know, which means that they act with a little bit more caution and a bit more accountability. So we've always had the situation where maybe a very novice nurse might come in and call up a GP very confidently and suggest certain doses of medications, which she may not have thought about. Actually, this patient has dementia, so that might not be the best drug in that situation, or this patient's nausea is being caused by this pathway, so that drug you've suggested is not the best drug for that situation. So having that kind of understanding about your own scope of practice, and actually you're on a very steep learning curve when you start in palliative care, and there is a lot to learn. Faye suggested that maybe we need to think about palliative care credentialing for nurses. Could provide significant clarity for everyone regarding nursing scope of practice. I think that that's a really good idea, Faye. Don't know what others think.
Yeah, hi everyone, it's Faye. I just wanted to speak to that. The Palliative Care Nursing Association some years ago did undertake palliative care credentialing, and I was actually one of the first nurses to be credentialed. It is actually very, very important so that we are able to confidently say when a recommendation is given by a nurse, then that nurse is within their scope of practice to provide a recommendation if they are not a prescriber. And I have a different point of view around CNCs offering recommendations. I think it's been tested now that with coroner's recommendations that it's actually it's a very fine line. If you are not a prescriber and we are not able to demonstrate scope of practice clearly around our professional work, then we just should not do it. I've seen this in my practice around, just as you said, a very confident young nurse coming along to do it, but I've also seen this in experienced nurses who do not prescribe, who will actually think they know best. But if you do not undertake a full assessment yourself, we should not be making recommendations if you are not a prescribing nurse. This changes everything in healthcare. We're settling for, I suppose we're settling in palliative care for and trying to fill gaps in healthcare. But there is a risk here, and there's been a lot of risks for nurses for a long time trying to fill that gap. I think we should stop, and we need to safeguard each other. We need to think about how we demonstrate this worth. And I think last time when the palliative care credentialing went away, it was purely over a financial decision. It costs a lot of money to do it. But I think if we were to ask palliative care nurses, would they have paid the money? I think many of us would. I certainly would pay some money to have the ability to say I'm credentialed, so that when I speak to specialty palliative care, then no matter who you are in healthcare, you know that that's coming from a foundation of knowledge and within scope of practice. If we don't have that, I'm concerned actually, because we have many people here where I work in CNC roles who actually have no experience in palliative care at all. We have CNs working in specialty palliative care with no experience at all. Do they like to take advice from a cautious older person who's prescribed? No, but that's on them. I get that. But in the mix of this are very vulnerable patients. And that really concerns me. I think we need to step back from it and actually say, what is our responsibility to our patients and our profession, and how do we, as really experienced nurses, take this brave new step forward? And what does it mean to be a specialty palliative nurse? It means a lot, and I think many of us would be keen to have something that says, actually, I'm meeting my standard. And I think I had to do something like 50 hours of education within palliative care every year to continue to be credentialed. The standard was pretty high actually. But I just want to put it out there, like there's many nurses that do a great job every day, but more and more young nurses are coming out, unfortunately, who are not getting exposed to the sort of nursing experience that many of us may have had in our journey. And so, making sure we stand for something matters.
Yeah, thank you, Faye. Look, I really, your point is I kind of, the point of this webinar really is that we need to kind of take a step back and think about what we can and what we can't do, and who decides that, and are we being safe? And ultimately, it's about the patient, isn't it? Kylie and Kathryn, do you have anything to say about that?
Look, I think that there's lots of good, valid points in what Faye's saying, and I think, you know, nurses are always at risk of, you know, legal consequences, you know, being called into a court of law if we've, you know, recommended the wrong thing. And so I think what you're talking about is actually really relevant. And which organisation, and this is something that Sophie had asked also, who was doing that credentialing back then, Faye?
I'll be honest, offhand, I can't remember, but we were linked in with the mental health nurses, the A&E nurses. There's a few others in a collaborative that were actually, through that collaborative, actually getting credentialed.
Okay.
And it was, you know, I thought it was a brave new step forward, and I really valued it. And then there was a financial thing. But Kim, who works at the Royal Brisbane Women's Hospital, she would know some more details, or any of the members through the PCNA a few years ago. But it was really worthwhile. And I think putting it back to the members and saying, if we know it costs some money, who's prepared to pay? I think lots of nurses might be, just as a thought, you know.
Thank you for putting that into the discussion, Faye. Like, it's a very, very interesting point. And I think with that, unfortunately, we're over an hour now, and we could probably be here for another hour because it is an interesting discussion, but we will finish. So Kylie and Kathryn, thank you very, very much for sharing your wisdom. Have you got any final words that you'd like to add?
Just that the references are on page 15 and on the slides. So if James can just skip through. So, you know, you can in your own time have a look at some of those documents if you'd like. And there's obviously a lot more work that needs to be done in this space. So we appreciate everyone's input and comments this evening. I know it's very often done in your own time. So we hope that you got something out of this webinar this evening.
Thank you for joining, and there'll be a survey that you will pop up when you leave, and I think the next webinar is about managing addiction and kind of managing addiction within palliative care. So that will be an interesting and more clinical webinar. So thank you very much for joining. Bye. Have a lovely afternoon.